I'm just going to go through some kind of statistics, risk factors, and then talk about just very briefly types of surgery and kind of get to the overall point, which is how to restore your body image after having breast surgery, and it's any kind of breast surgery. So I am a general surgeon, so there is no board certification for fellowship trained breast surgeons. But after I finished general surgery, I did a subspecialty training in just diseases of the breast. So we spend half the time operating, but the other half of the time we actually spend with the medical oncologist and the radiation oncologist and the breast radiologist and the pathologist, kind of learning the whole, 360-degree view of what patients go through. I don't have any disclosures, so I am with Texas Breast Specialists. My location with Texas Oncology is in Willowbrook, serving the Northwest community. We also have a breast surgeon at Women's Hospital. We have them in Webster. We have a fellowship trained breast surgeon in Kingwood. We have another fellowship trained breast surgeon in the Woodlands. So most of the areas are covered, but what's unfortunate is that access to a lot of the stuff you see downstairs is, for such a big city, is difficult to find. So just a little bit about me. I am originally from Charleston, West Virginia, which is a state all of its own since 1863. Most people don't realize that it is one of the 50 states, and Charleston is actually the capital, not the good one, or the one that's getting hit by a hurricane today. So that's where I grew up. I went to college in Ann Arbor, Michigan, and my undergraduate degree is actually in political science. Then I went back to West Virginia and did medical school in Morgantown, West Virginia, which is in the northern part of the state. Then I went back to Charleston. I did my general surgery residency there, and then I moved to the western suburbs of Philadelphia and did my fellowship there. And I came and I interviewed all over the country, and I came in January. And then 2 days later, when I got home, we had what they called a nor'easter. So this was a blizzard, and I was like, I'll take the job. I'm done with snow. So just the objectives, I'm going to go over some cancer statistics, risk factors, things that increase risk, decrease risk. I'm not going to talk too much about breast surgery, just going to say kind of overall what the general options are. We're going to talk about axillary surgery. Axillary refers to the lymph nodes that are, technically they're not in our armpit, they're actually underneath the major muscle underneath that is a pec minor, and these lymph nodes kind of sit in relation to the pec minor. So I usually say armpit, but then people are really sore after surgery, and it's because the incision's this big that I'm this far inside. We're going to talk a little bit about breast cancer-related lymphedema, monitoring, and then restoring self-confidence in men and women who have had breast cancer, and then barriers that we have to restoring their body image and how to obtain the appropriate garments, prostheses, etc. for those patients. In general, any type of cancer, but in breast cancer, it's always caused by some mistake in your genes. So something goes wrong in the genes, and that causes cancer. Only about 5 to 10% of breast cancers are genetically linked. So the other cancers are typically found just because somebody is unhealthy. So there is nothing that we know that directly links the other 85 to 90% of women to be more prone to getting breast cancer. So about 1 in 8 women in the United States will develop breast cancer. So It's 12.5% of women. And these are the most recent statistics I found. So in 2022, it was estimated that about 290,000 new cases of invasive breast cancer are expected to be diagnosed in women, and this obviously was data that they got prior to 2022, but they are trying to project. And then along with about 5,100 cases of non-invasive breast cancer, which I'm happy to explain, but we treat both of them very similarly. I just don't want to get too far into the differences in breast cancer right now, just because I have a limited amount of time. About 2,700 new cases of invasive cancer are expected to be diagnosed in men. A man's lifetime risk is about 1 in 833. So, since I've been in practice in Texas, I've diagnosed 1 male breast cancer. About 43,000 women in the US are expected to die from breast cancer. Of cancer deaths in women, breast cancer is the second leading cause. Ovarian cancer is the first. Fortunately, death rates have been steady since about 2007 and have continued to drop. That's for women under 50, and women over 50, they've continued to drop since 2007. And the overall death rate from breast cancer has decreased by 1% between 2013 to 2018. These decreases are thought to be a result of treatment advances and early detection through screening, and our modalities for screening have also gotten better, so we're finding things earlier and smaller, which makes treatment less aggressive and improves overall survival, which is how long we live. More statistics. For women in the US, breast cancer death rates are higher than those for any other cancer besides lung cancer. This, I think, is older from one of the last ones, because I just said ovarian cancer is number 1. There are more than 3.8 million women with a history of breast cancer in the United States. This includes women who are currently being treated or have finished treatment. So currently there are more women living with breast cancer or a history of breast cancer than any other time, because our treatments are so much better. It's the most commonly diagnosed cancer among American women. It's estimated that about 30% of newly diagnosed cancers in women will be breast cancers. Breast cancer became the most common cancer globally as of 2021, and that accounts for about 12% according to the World Health Organization. In women under 45, breast cancer is more common in Black women than white women, and we also know that in Black women, the types of breast cancer they get tend to be more aggressive types of breast cancer, which is probably on another slide. So because they are more likely to get more aggressive types of breast cancer, they are more likely to die than white women or men. Most of this is based on women, because so few men get breast cancer. Most of our studies are all based on data we get from women, and we extrapolate it to men who develop breast cancer. For Asian, Hispanic, and Native Americans women, the risk of developing and dying from breast cancer is lower than for Black women, but still with access to health care, it's typically white women that do better long term. Ashkenazi Jewish women, so that is Eastern European, Ashkenazi means Eastern European Jewish descent. They have a higher risk of breast cancer because we find genetic mutations more common in the Ashkenazi Jewish population. So, for example, my whole family, we're all Eastern European Jews, and my sister-in-law actually has a BRCA mutation. So the BRCA mutations tend to put women at a significantly higher risk of both breast and ovarian cancer. So going back to kind of the incidence rates, we think a lot of the reason why in women over 50 the rates have dropped is because for a while we were doing hormone replacement therapy with estrogen and progesterone, and after a lengthy study, we found that especially if you've been on progesterone, hormone replacement therapy significantly increases the risk of breast cancer in postmenopausal women. A woman's risk of breast cancer nearly doubles if you have a first-degree relative, and that includes if you have a child. So actually the risk is higher for a parent if their child has developed breast cancer than for a child if their parent has breast cancer. Less than 15% of women who get breast cancer have a family member, which we talked about. Mutations, so the two biggest risk-related mutations are the BRCA1 and the BRCA2 genes that have abnormalities. On average, women with a BRCA1 mutation have a 72% lifetime risk of developing breast cancer, and this can vary based on family history. For women with BRCA2, the risk is still very high. Breast cancer that is positive for BRCA1 or BRCA2 mutations tend to develop in younger women. We also know that in BRCA mutation patients, there are certain types of chemotherapeutic agents that work better in BRCA mutation carriers. It is a dominant gene, which means that you only have to have one copy of it. And if you are a carrier of it, each child, male or female, have a 50% chance of receiving it from a parent. So, for example, my sister-in-law, her mother is actually the carrier. There's a long story about why she ended up getting genetic testing, but we found out it was her mom who's a carrier and her two sisters are negative. So 50-50. So you never know what's going to happen with these genes, but I also don't recommend that children are tested for these types of mutations. We actually don't have any types of screening that we do for women until they're about 25. Because of breast density and other reasons, it's hard to detect abnormalities in women who are very young. In men, BRCA mutations, especially BRCA2, are associated with an increased lifetime risk. We see BRCA2 mutations in men more commonly than we do it with BRCA1 mutation. So typically, if I see a male with breast cancer, they get genetic testing, and if it does come back positive, it's more likely to be a BRCA2 than BRCA1. The two biggest risk factors for developing breast cancer are being female and getting older. So two things that we have absolutely no control over. So as we get older, our risk increases. Family history, if you have a significant family history, if you have a family history of anybody with ovarian cancer, we recommend that you have genetic testing. We see ovarian cancer most commonly in women who have genetic mutations. So if anybody in the family has had ovarian cancer, you automatically qualify for genetic testing. If you've had breast cancer before, you are more likely to develop a second breast cancer than someone who does not have breast cancer. We typically don't see a lot of this anymore, but if you've had a lot of radiation to the chest or face before the age of 30, we've talked about race and ethnicity, being overweight, so we know that maintaining a healthy body weight, exercising, limiting alcohol intake, all help reduce the risk. Our body fat stores estrogen, and a lot of breast cancers are driven or fueled by the estrogen that we make. So even in postmenopausal women, we still produce estrogen from our adrenal glands. And breast cancers that are sensitive to estrogen, that's kind of the fuel that's driving the cancer. So in women who are overweight, they're storing extra estrogen in their body fat, and that's why they're at increased risk. Breastfeeding history, if you breastfed, slightly reduces the risk. If you started your menses late and went into menopause early, that slightly reduces the risk. Smoking is bad for everything. I can't think of a situation where smoking it, we're like, go ahead and have a cigarette. And then, like I said, limiting alcohol intake. Kind of talked about this, being female, getting older, family history. We talked about genetics, personal history, breast cancer, and then radiation. Again, this is just sort of all the stuff I already talked about, so we'll kind of skip through that. Pregnancy history, we know that if you have a child before the age of 35, I think it's actually 30, slightly reduces your risk. Like I said, breastfeeding slightly reduces the risk, although I always tell my patients when I ask these questions, they're not judgment questions, they're just questions. Having a child younger, breastfeeding, it's not a significant risk reduction. So people will say, I exercise, I'm vegan, I breastfed, I had children young and they still get breast cancer. And I have people who do everything wrong and they still get breast cancer. So there's just no way to know who's going to get it. That's why screening is so important. So exercising, smoking, and then limiting alcohol intake. There are studies that have shown that limiting alcohol intake and maintaining a healthy body weight both decrease your risk. So treatment for breast cancer is typically multimodal, meaning it's not just one thing. It's not just surgery, it's not just radiation, it's not chemotherapy, it's not drugs that help block or turn off estrogen production. It's not just certain targeted therapies. It's sort of, I tell everyone it's a team sport. So in breast cancer, I think it's important to understand breast anatomy. So breast cancer typically comes from one of two places in our breast. So our glands are made of two things: the lobules, which is where milk is produced, and the ducts, which I think of as little hoses or pipes that carry the milk from the lobule to the nipple. So we most commonly see breast cancer either arising from the lobule or from the duct. Without getting too much into the specifics, there are a few different options when it comes to breast surgery. There's breast conservation, where we can remove the cancer but keep most of your breast tissue. And the other option is a mastectomy. And some people opt for prophylactic mastectomy. So for example, in BRCA mutation carriers or other carriers, a lot of times they will have prophylactic mastectomies, meaning they don't have cancer, but their risk is high enough that they're trying to prevent it. So a lot of these patients, we call them previvors because they're trying to prevent cancer from developing. So prophylactic just means they don't have any active disease or trying to prevent disease. So when we talk about, this was basically what I just said, so there's breast conserving surgery, and for any type of breast conserving surgery, these are all for local control. So the example I like to tell patients is, imagine that there's a cabin in the middle of the woods, in the middle of nowhere, and it burns down. Does it affect anyone else? And the answer is probably not. So surgery is for local control. So surgery to the breast and surgery in the lymph nodes, which we'll get into in a minute, kind of help us determine what's going on in the rest of the body, but surgery alone is for local control only. So nothing I do actually changes how long someone lives. It just changes the risk of getting cancer in the breast again or in the lymph nodes. In a simple mastectomy, there are multiple ways we can do this. It's just simply removing the breast tissue. So I don't have a microscopic vision, so having a mastectomy does not decrease the risk to 0. We know that in breast conserving surgery, we leave little microscopic bits of cancer behind, so women often, and if you are following the standard of care, if you have a breast conserving surgery, then you will also have radiation, because radiation is like a cleanup. Imagine you shatter a glass on the floor. Every man I've ever dated thinks that a burn and dustpan is the greatest way to clean that up. And I think we all know that you're the one that's going to step on that shard of glass in the middle of the night. So radiation is like a Swiffer. It comes in and cleans up the area. So typically we treat the whole breast with radiation afterward, which is basically burning tissue. So it causes a lot of scarring. What I like to do for breast conserving surgery or partial mastectomy or lumpectomy, it goes by 100 different names, quadrantectomy, is when I operate, I like to use hidden scars. So even if you have a cancer out here, a lot of times if you're smaller breasted, I can go underneath the breast along that inframammary fold, or I can go around the areola, even sometimes from the armpit, because I think this is important, because when you have a scar in the middle of your breast, it's something that you have to look at every day. And well, in the beginning, a lot of patients will tell me they don't care what it looks like. I promise in the long term you will care. So my job is to not help you figure out what's right for today, it's to help you figure out what's going to be right in the future. So there's some pictures ahead that show breast. So I know there was a young man here before, so I just wanted to make sure that everybody knew I was going to be showing breast pictures. So go ahead, just look at it again. Maybe too much animation. Really, these are just some images of things that happen after you have a lumpectomy. So asymmetry is one of the biggest problems that we have. So after radiation, typically you get lifting of the breast, you get some shrinkage, and you get firmness of the skin. And so I tell everyone, you know, if you're 65, that breast is going to be 65 forever, but your other breast is going to continue to age. So the asymmetry women have after a lumpectomy, and especially if you have a larger cancer and you're not working with someone who's thinking about being symmetric, a lot of times what I will recommend patients do is if they're larger breasted or they have what we call ptosis, so instead of the nipples facing across the room, over time they start to face down. We can actually do a lift of both sides. I get a plastic surgeon to help with that so that you are more symmetric. So these are changes we see after lumpectomies, and most of the time, if I'm removing tissue for a non-cancer, we don't get a lot of this asymmetry. Go ahead to the next one. We did it a couple times. So don't worry about where the implants are. I just wanted to try to show some pictures. So the very top picture is showing pre-op, 1 month post-op, 3 months post-op, and 6 months post-op. And at the top, so these are women who had mastectomies, and then the bottom 3 show women who had breast radiation. So post-mastectomy radiation therapy is what PMRT stands for. And you can see that a lot of them end up getting, so we always sample lymph nodes, and a lot of times that's through an incision in the armpit. So as things shrink down and get pulled from radiation, we'll see the breast pull one way or the other. In breast conservation, if you don't put tissue back together, I think of it like a tarp over an empty pool when it rains. Everything gets sucked in. So there are different holes in the breast. So if you have a cancer kind of in the lower central quadrant and someone doesn't put tissue in there, they just take something out and close it up. Initially it looks good because your body will naturally fill that with fluid. And then after you get radiation, it'll start pulling it in and it can pull the breast down. So I see a lot of women with folded over breasts where their nipple is kind of touching their chest wall from surgery they've had in the past. And then again, these are just some examples of what happens. I think, even though it says bilateral, I really think these were unilateral just based on their images. Meaning, instead of it being both sides, it's just one side, but you can see that there is a difference. In the top one, so this patient had no radiation, and this was talking about where we put the implants, if you're having implant-based reconstruction. So it used to be, kind of the pendulum swings both ways. So it used to be that we would put it under the pec muscle, but then every time you use your arm, we end up seeing what's called an animation deformity. So every time you use your pec muscle, it goes up and down, so your implant goes up and down. So what we often do now is the plastic surgeons will kind of make a little hammock, and we put the implants in front of the pec, and we get better outcomes. But we try to do different types of reconstruction if we know that a patient's going to need radiation. Sometimes we don't know ahead of time. So in the bottom picture, you can see this patient has some interesting scars, but where the scars are after the radiation, even with the implant in place, it's caused deformity of the breast. So you can get change in the breast form following post-mastectomy radiation. It causes muscle fibrosis, which is just scarring of the muscle. Superior lateral just means to the top and to the outer side of the breast. So superior is this way and lateral is this way if you're on this side. Superior is this way and lateral if you're on the other side. So what that means is the nipple and the areolar complex are going towards your armpit, which is what we see a lot after post-mastectomy radiation, and even wherever the scar is for breast conservation. If it's not, if there's no kind of, think about it like a scaffolding, if there's nothing for the skin to lay on top of, you're gonna have pulling in those directions. Patients will also see dimpling and creasing of the soft tissue. It also can cause scarring of the muscle. So patients who have no reconstruction and then get radiation, a lot of times the skin, you'll have scarring of the skin basically with the muscle on the rib, and so it's really difficult for them to have arm movement. They have a lot of issues with range of motion. You can get frozen shoulders if you're not careful about getting into physical therapy. Just very quickly, the axillary anatomy. So in breast cancer, part of our staging and helping us identify what's going on in the rest of the body is by sampling lymph nodes. So the old way we used to do that is the lymph nodes that are in the axilla, so they're beside, they're beside, behind, and then medial towards the middle of the pec minor. So there are 3 different levels of lymph nodes that we focus on, and the breast has a very rich lymphatic supply. And so we think the most common way we see lymphatic spread, about 95% of the lymphatics from the breast drains, about 95% go into the axillary lymphatics, and then there are some that run along they're called the internal mammary, they run along kind of the midline of our chest, and then there's some that are above our clavicle. Those are called supraclavicular, supra just meaning above. Go to the next one. So anytime that we operate for breast surgery, there is always some sampling of lymph nodes. The old way we used to do it is we would go in and we would identify the axillary vein, and then there are two really important nerves. So the long thoracic nerve it's a motor nerve, and the long thoracic nerve innervates the serratus anterior. So if we injure that, it can keep you from going from parallel to above the head. And the thoracodorsal nerve, which is in a little bundle that runs right along the chest wall, that innervates your latissimus muscle, which is one of the big muscles in the back. And if you injure that, it can cause a wing scapular. Your shoulder blade kind of sticks out, and if you injure both of those, you can end up with shoulder girdle dysfunction. When we have to do axillary lymph node dissections, it's usually if patients have bulky disease. There are various reasons why we do it, but I would say it's less common, and I try to do everything I possibly can to not perform that surgery. So a sentinel lymph node biopsy, what someone who's much smarter than me figured out is that when the drainage from the breast to the lymph nodes happens, there is a set of gatekeepers. So the sentinel is like the first line of defense with an army. And in order for cancer to get into the rest of the lymph nodes, you have to go through these gatekeepers first. So we're able to inject either a radioactive substance, which then I have a probe that measures radioactivity and I can find the nodes, or we can do blue dye, and sometimes we do both. So either the nodes are radioactive or they're blue, but the less surgery we do to the lymph nodes, the less likely you are to get breast cancer related lymphedema. This is just a depiction. So they always make the lymph nodes green. The arteries are always red and the veins are always blue, but they don't look like that in reality. So in the axilla, there's a fat pad, that's sort of this light glistening fat pad, and the lymph nodes are sort of these white, light pink glistening little things that are kind of hiding, like an Easter egg hunt, in the fat. So the probes help us guide where the lymph nodes are, so we are doing less kind of trucking through there and being more specific about our dissection. Because again, the more, even if we only remove a few nodes, if you're very rough in your dissection, you can disrupt a lot of the lymphatics. So in a lymph node dissection, basically what I do is I find those two nerves I was talking about, and then the axillary vein, and the edge of the pec, and then that entire fat pad just gets, basically, you don't dissect it, because with cautery or scissors you can cut something inadvertently, you can burn something inadvertently. So we literally are just pulling the tissue out. So we know that we are significantly injuring the lymphatics, and we know that we're injuring a lot of the sensory nerves to the arm. So there's a handful of sensory nerves that can be damaged as well. They can use sensation to the back part of your arm, down to the elbow, and with an axillary lymph node dissection, most of the time that sensory loss is permanent. As the number of nodes that are removed goes up, so does the risk of lymphedema. So on top of that, if you add radiation, whether you've had 2 or 3 lymph nodes removed or 25 lymph nodes removed, that also adds extra risk, because again, radiation is causing scarring and can cause the scarring of the lymphatics as well. So if you have whole breast, and then because of certain characteristics of the lymph nodes, they add the supraclavicular radiation. Those patients are at the highest risk if you've had an axillary dissection, whole breast radiation with addition of supraclavicular fields. So those patients are pretty much guaranteed to get lymphedema, and we're trying to send them for lymphedema teaching and things to look for, but that we'll get to the barriers shortly. It gets really exciting. So monitoring for lymphedema. So in the past, we haven't had great ways to monitor. We can use a tape measure for measurements, serial measurements, but that's can be inaccurate and user dependent. We've used water displacement, which I don't think really anyone uses anymore, and the bioimpedance has been one of the greatest things you can use to check patients very non-invasively for changes in their arm before. So we check patients before, after surgery, and then we follow them up. So actually there is a big trial called the PREVENT trial where they used bioimpedance. Bioimpedance is essentially tracking electrical activity through the water in your body. So we know which arm is affected. We do a baseline screening. So you put your hands on two kind of things that are, will have some electrical activity that you can't feel, and then your feet go on, and it tracks through the whole body. So we do a reading before surgery, we do them at intervals after surgery, and continue to follow patients. And the goal of this is to find lymphedema before it becomes clinically evident. So the PREVENT trial is looking at arm measurements versus the LDEX, which is now called a SOZO. But to the next one. So when they did the trial, they used tape measure, and then that, they tried to keep it as standard as possible. And the initial results showed that basically they found in subclinical lymphedema there was a trigger. And so when we made an intervention, meaning we put somebody in a compression sleeve and a gauntlet. So the gauntlet is, so it's a hand garment as well as the arm garment. And what they found in this study, which has already been published, the next one, is that they looked at 1,200 breast cancer patients. They looked at 10 centers that included 6 centers that had. So the NCCN is the National Comprehensive Network, and that basically tells us the standardized guidelines of how to treat any cancer. And then NCI is the National Cancer Institute, and so that means that your institution has to have a lot of things in place to get this awarded to them. And so they did a 1-to-1 randomization and looked at patients who did the LDEX versus tape measure, and what they found is that, so they did measurements, go back to this one. They did measurements 3, 6, 12, 15, 18, 21, 24, 30, and 36 months. And this was the initial study, and then they had some secondary outcomes, which I'm going to talk about. And basically, with this machine, if your number moved up or down, it didn't matter where you started, just that 6.5 trigger, then we would make an intervention and then keep rechecking. So the idea is to prevent you from developing chronic post-breast cancer lymphedema. This just showed that from progression to chronic lymphedema with LDEX versus a tape measure was significantly better if we use LDEX measurements. And then the triggers, we actually were triggered, the triggers and then the interventions There's less triggers, but more beneficial interventions. So, what they just published one more time. So this actually was published yesterday. So they are looking at secondary endpoints. And what they did is they looked at lymphedema symptom intensity and distress. They did a survey, and this was a 30-item survey, and it covered 7 different clusters, looking at soft tissue, neurological sensation, function, biobehavioral areas, resource, sexuality, and then activity, meaning, getting out, exercising, socializing with friends. And then the functional assessment plus the 4 was a 36-item functional assessment, and then it added physical well-being, social and family well-being, emotional well-being, functional well-being. There was an arm-specific quality of life concern that also added, so painful arm movements, poor range of motion, numbness, stiffness. So go to the next one. So what they found is that progression happened to chronic breast cancer-related lymphedema, which is the BCRL stands for, an axillary lymph node dissection and some type of chemotherapy. Patients often progress through chronic lymphedema. A higher level of change in the LDEX units at the time of detection from the baseline, statistically significantly correlated with higher overall symptom scores, high specific soft tissue issues, neurological, and higher issues with sexuality symptoms. So at the time of subclinical, which this is very interesting and kind of goes back to my point. At the time of subclinical breast cancer-related lymphedema diagnosis, they found that a lot of patients were still having what I think are a lot of psychological issues that come along with having a breast cancer diagnosis. So they saw a decrease in social activity. They saw patients giving up on hobbies, decreased sexual activity, and this is whether you diagnose them with subclinical breast cancer-related lymphedema or chronic breast cancer-related lymphedema. They still were having functional issues, sadness, anger, lack of self-confidence, appearance issues, being misunderstood by their significant other, loss of their sexual attractiveness, loss of their body confidence, fatigue, and sleep loss. And so I tell everybody that it's important that you feel good after you've had a breast cancer diagnosis, because I think about it as if you gain weight and none of your clothes fit. Nobody wants to go out and leave the house and see their friends and be social. And if you wake up every morning and you have chronic lymphedema, if you have surgical incisions that are very apparent, if you have asymmetries, if you can't wear clothing without feeling like one side is obviously bigger than the other, or you can't find a bra that fits after you've had breast surgery, whether it's a lumpectomy or mastectomy, with or without reconstruction, regular undergarments don't fit anymore. Sometimes with, so these are all things, we know that all of this stuff happens. But why are so many people not able to get what they need? And I think it's, one is cost and insurance, and the other is access. So we'll do the next one. And some of it is the side effects of the medication. So for women who are on anti-estrogen medication, that medication causes hot flashes, vaginal dryness. In some cases, some of the medications can increase your risk of DET, some can increase the risk of, or increase the rate of bone density loss. But if anyone wants to come in, just come on in. But I find, it's not just how you feel physically, but if you're having significant vaginal dryness and no one's treating that and no one's asked you about it, being sexually active is very difficult. And so it was one of the things that maybe because I did my fellowship with a male breast surgeon, but they never asked the male breast surgeons about vaginal dryness. So I always try to ask patients about how they're feeling, about symptoms. Are they dating again? What is their intimacy like with their partner? And so the problem with all of this is the LDACs, or that was the older version, now it's called a SOZO, is that reimbursement isn't great. So to get, your organization to get a machine to do these measurements, it should be standard of care. And actually, if you are trying to get accreditation for, it's called, there's a national accreditation program for breast centers, having care plans, monitoring lymphedema, these are all things you have to do. Having multidisciplinary, what we call tumor boards, where we discuss you preoperatively and postoperatively, make a plan as a team. Those are all things that you have to do. But what I have found is that we have a lot of trouble with access. So when I was practicing, I was in kind of the Northwest area, but also in the Woodlands. There's not a lot of things out there where people can get fitted appropriately for lymphedema garments. They can't meet with a certified mastectomy fitter. So I would send people down to the Women's Health Boutique, which was on 1960. Now they have a beautiful new place just past the Vintage. But in patients whose insurance won't cover it, it can be a huge barrier. For women who are able to get it, it's amazing what we can do now. It's, you can get a custom breast prosthesis, I think. I was told it's either 150 or 180 different skin tones that they can match, because I think that's important, right? Nobody wants a prosthesis that doesn't look like them. If you have asymmetry, instead of having to undergo another surgery, sometimes I tell patients, we give them what I call a little chicken cutlet, that you can wear in a bra, but a bra that is made for women who've had breast surgery. So it's not an augmentation. These are patients who have, if you have a mastectomy, it's skin and an implant. There can be loss of that intramammary fold. So, to try to go to Nordstrom and get a bra that fits and is comfortable is nearly impossible. What is great is if you've been downstairs on lunch, they're getting even better at the stuff that they make, because now they have bras and panties that match, which I think is amazing. But I do think that there is a bigger need, especially in a city as big as Houston, where we treat tons of breast cancer. There is just not enough access. And for women who socioeconomically are not in as good of a place as other women, if you're on, a marketplace plan, if you're on Medicaid, a lot of this isn't covered. And a lot of women who have stuff that's covered don't realize it's not just one bra and one prosthesis. You can go back every year. Sometimes I just put 12 of everything on there, and that you'll need it indefinitely, and that you need to be renewed every year, so they don't ever have to get my permission for a prescription ever again. So I think that is it. These are my children. That's my cat. He thinks his name is Dave. That's my dog, Winston. And then, you want to go to the next one? I think we have some profile cards. This is all of my information. So I know I'm right at 1:30, but if there are any questions that you have, I'm open for questions now, or if there's stuff you want to talk about on the side, I'll be around most of the day. Yeah. So the question was about mental health needs, and that is also another huge barrier. So there just isn't enough. I mean, most really good therapists don't take insurance. Is what I found, and so patients really that, and especially if you've had cancer, you need a therapist that understands the issues that you're going through, not just in your life, but your whole life changed. It's like you were going down this path, and then the minute someone said cancer, it goes a different direction. And in the beginning, you have all these things that you need to do, and then all of a sudden, mentor of mine, she wrote a book and she calls it The Cliff, where now you're done with all these things, and what do you do? I think that's when, access to counseling, therapy is super important, and we don't have access to that. Some patients can afford it. Some patients will have stuff through work, but it's maybe 8 sessions. 8 sessions probably covers like the first 6 months of my life. So, yeah. So I think that's another big barrier that we have. Not just body image, but it's, it's all of these things. And the other person that often gets forgotten is somebody's partner. They don't have a lot, there isn't a lot available for my patients' partners. They're struggling too, because now they have a significant other who has lost her sensuality and sexuality and her drive to be intimate, and that is difficult for both of them. But for someone who's had cancer or has cancer, it's very different to be on the other side of that as well. And I don't think there's support for partners enough either. So I don't have, the other thing is I can't get a lot of my patients to go to therapy, but I think a lot of it is because it's just hard to find someone to see them, somebody that they can relate to and tell them, it's like going on a date. If you meet with a therapist and you don't feel a little bit better when you walk out, that's not the right person for you. And sometimes patients don't have the option to go to someone else. There's support groups, but if you're 32 and you're in a support group with someone who's 78, you have different issues. There are some groups in and around the Houston area. There's a group called For the Rest of Us. They're having a big gala on October 12th. It's called We Run This. So it's a group that focuses on women of color. So it's a big fundraiser for that. There's another group called the Breasties, and that's geared more towards younger women, previvors as well as survivors. But I do think that there are so many different needs that just aren't being met for breast cancer patients. And that includes all the stuff that we see downstairs. Some women just don't have access to it. And so, we get some donations, but you're trying to make a sleeve that doesn't exactly fit, or maybe I think they need a higher amount of compression. So because I did my residency in West Virginia, we had a lot of smokers, so we had a lot of venous insufficiency, we have a lot of wounds. I was like, oh, this is all the stuff I used to do when everybody was talking. But that's one of the issues is, I'm used to getting people into compression, and it's hard when they need maybe 20 to 30 or 30 to 40, or they, over time their lymphedema has improved and they need a different size sleeve now because they're very religious about using it. So that's another problem that we run into is maybe you need a different size now that things are well controlled. The other thing that I tell patients is, I forget who mentioned it, but gardening. You just have to be careful with your hands. And don't let them cut your cuticles if you're gonna get a manicure. It's just the smallest thing that will just stimulate a huge, inflammatory reaction. And you never know what that's gonna be. You could be walking in the house and brush up against something and it can happen. but having access to a certified lymphedema therapist is extremely important. And those are hard to find, and they're hard to find for coverage for patients. I initially met him because he was working with a company that sold pumps, and he came to my office, and then I saw him like a few months later at the American Society of Breast Surgeons meeting, but with Kathy Bates. And then if anyone has any other questions? I'll be around. That is my, that's my cell phone number and my email. If you want to see me in the office, the profile cards have a different number, so if you have a pen, which I think, just make sure that 281-671, where's Sonia? It's my new patient coordinator, and then Deborah in the front here is my nurse. And then this is our liaison extraordinaire, Joe. So if you have any questions about anything, you can get with one of us. But I think that's it.